Good afternoon. May I request your kind attention? First of all, let me welcome you all to this afternoon pre-lunch session titled The Emerging Troika and New Agenda for Global Health Governance. We've seen tremendous amount of global health governance inequity during the COVID-19 pandemic. Today, as per latest statistics, 80% of Africa is still not vaccinated for COVID. 70% of vaccines here in Africa comes through the Gavi, and a lot of the remaining comes through various bilateral arrangements. The presidency of India at the G20 later this year, the presidency of Brazil the next year, and the presidency of South Africa thereafter offers a once-in-a-lifetime opportunity to bring the priorities of the least developed nations and the developing nations at the high table of global health governance. Starting with India, we need to look at creating mechanisms, institutions, processes, and governance practices, and consolidate it over the next 3 years of the 3 successive developing nation presidencies. How do we do that? What is it that we need to do? And fortunately, we also have South Africa, which is taking up the BRICS presidency later this year. So these portend very well to bring the agenda and priorities of the Global South to the high table of global health governance. I have with me a very power-packed panel this afternoon, and allow me to introduce them, starting from my left. Grace Akello, the High Commissioner of Uganda to India and Professor of Medical Anthropology, Faculty of Medicine, Gulu University, Uganda. Welcome, Your Excellency. On my right, Ravi Mittal, Chief Executive Officer, District Council, Raipur, the Government of Chhattisgarh, also one of our emerging and star-packed civil servants in India. Welcome, Ravi. Priya Balasubramaniam Kakkar, who is a Senior Public Health Scientist, Public Health Foundation of India, and the Director for Sustainable Health Innovations of Singapore. Welcome, Priya. And Mr. Jose Siri, Consultant Urban Health at the World Health Organization, United States. So I'm going to ask my panelists the questions, and of course we can all intervene, all of us in this room. So I'm going to start with Grace. Your Excellency, we've seen Africa ravaged time and again. COVID has been, of course, the elephant in the room, but we had the World Health Organization declaring a health emergency in 2019 for Ebola, 2022 for monkeypox. Monkeypox has been endemic, and both of these have been endemic in countries of Africa for over 50 years. Monkeypox alone for the last 50 years in 11 countries of Africa. What is it that the emerging G20 Troika do to bring to the high table the priorities of developing nations, and what's the African perspective? What's the African expectation?
Thank you very much, and I want to thank the ORF for inviting me. My name's Grace Akello, but we have so many Grace Akellos in my country. Yes, this one we have always to negotiate and to know which Grace Akello. In this forum, I had to ask a few questions. For instance, 2 Grace Akellos with PhDs, highly skilled. I am the professor of medical anthropology. Yes, and there is another Grace Akello, also very highly skilled. She was the Indian High Commissioner for a few years. So I am very happy that that was clarified in the beginning. So it is in that spirit that I am very much interested in this topic, the tracker, and the emerging powers, yeah? Deploying global health diplomacy. Indonesia, Brazil, and India. These three actually have been working together since 1955. During the Badang conference, you will notice that they came together and they were asking a few questions and they were designing strategies and they even put in place principles, yeah? Principles to help them deal with their own priorities and to deal with their own issues. For instance, they were guided by the principle of self-respect. They were guided by the principle of non-militarization. Remember 1955, that was a transition from the Second World War. And these countries, full of good ideas, were asking, as a way forward, how do we take care of our priorities? Non-militarization was one of the principles, and non-interference in foreign or with sovereignty. These are some of the very good principles which I asked myself when I was coming to this conference 67 years later. What went wrong? Why don't we see these three countries cascading these principles even to Africa? But I want to appreciate what they did during the global pandemic, because this is really now my specialty, global health, and how these countries deploy diplomacy or soft power or influence in countries like Uganda. It is a South-South cooperation, but they come with not only technical assistance, they come with also financing. They come with knowledge that Ugandans, for instance, can benefit from. Africa in general. You know that in Uganda, if I must tell you, there are very complicated cases in health, especially non-communicable diseases. This has been subtle. This has been for many years that surgeons, heart specialists, we have pediatricians referring clients to India, referring clients to like South Africa even. And this we can't underestimate in healthcare. It is a way of cooperation. It is a way of benefiting from knowledge, but it's a way also of leveraging this technical assistance that these countries provide. Yeah, and then during COVID, and this is very important, the Serum institution in India, it provided many batches of AstraZeneca to Uganda, and this is a time when there was so much debate about who is getting what, who is eligible for which vaccine. But Serum even wrote memorandum of understanding with our Ministry of Health, yeah, and good terms of reference. Can you afford to pay this much for COVID vaccine batches? It was unfortunate that there was some interference there, but it was in good faith. That we have this knowledge, we can deploy it, we can cooperate, and we can share in this era of COVID, yeah? And then I will give us an example of this South-to-South cooperation. I don't know about other countries in Africa. Africa is very broad, so I will only narrow down to what I know best. Uganda and its experience with this tracker and these three global economies that want to deploy soft power. Yeah? Global health diplomacy is really about power, but it's also about cooperation and so about sharing knowledge and facilities even. At a time when the global South was asking so many questions about being left behind, and we know global health was the champion of this phrase, nobody should be left behind. As early as early 2000s, they adopted this phrase. You go to conferences, global health conferences, yeah, and there is no one to be left behind. But we know that some of these things are good on paper. When it comes to real practice, especially like during COVID-19, we saw that, okay, we've been left behind, but there is hope for us. We have partnerships, we have linkages with our neighbors, we have India, we have Indonesia, we have South Africa, in fact. And in global health, there is this debate about human rights and access to medical technologies. And I am not very much fully in support of the TRIPS, how to make sure that people get medicines no matter what. Yeah, these pharmaceuticals take time to be developed, and it is really patent rights here. We have to tread carefully for someone to find the active ingredient of any medical plants. It takes time. It takes effort. It is an intellectual property. So how to negotiate these things? We know we have lower budgets. But we need these technologies as well. We need the pharmaceuticals. We need the vaccines. So I know that India, I know that South Africa, I know that Brazil, they have championed this TRIPS issue. They have advocated for generic type of pharmaceuticals, and it is an ongoing debate. I don't think it will be resolved, but these things need to get to people who will use them. Yeah. My colleague and medical anthropologist Paul Farmer said that if there are medical technologies out there, and especially they are for communicable diseases, they will get back to Africa. They will, and they need to be there in affordable way, in a way that is not violating the rights of the developer, right? And these are the things that I want to pose in this deploying global health diplomacy and soft power by southern countries to southern countries, but also the global north has a crucial role to play that we cannot ignore, and we need to acknowledge this.
Thank you, Your Excellency. And it's very ironic. And you raised Bandung, and that was in 1955. Yeah, that's 67 years to the date. Yeah, 67 years. And Bandung was supposed to be the cornerstone for the Asian-African cooperation. 67 years later, we have really not had much, our ideas and our systems have not had much legs on the ground. So that turns me to Ravi. And Ravi, you're part of the government in India. And what is it that, in your view, is going to be the government's approach, and what kind of frameworks should we strive in the three presidencies, India, Brazil, and South Africa? And particularly, what is it that India could, in its own capacity, contribute to building capacity, health, governance, and pharmaceutical capacity here in Africa?
First of all, thank you. So, this is not really a Troika. So, we have the four developing nations: Indonesia, India, Brazil, and South Africa. So, it is even better than the Troika that we have the four nations who will be defining the G20 agenda for the next 4 years. So, going forward, since we are in a much responsible position, so it is important that to have a long-lasting impact of any initiative or the priorities that we set up, there is a need to strike the balance between the necessities of the global north and the global south. And at the same time, the priorities should be defined in a very concrete ways. Too many priorities is like having no priority at all. And this is what we are seeing with many multilateral organizations, that due to their over-expansion of the mandates, the outcomes are not really what we expected, what the different governments expected from them. Then whatever policy decisions or whatever the priorities we set up, they must be continuous. They must resonate even beyond the 4 years of presidencies of the developing countries. And there, I believe when we talk about the framework, we must make sure that duplicity of efforts should be avoided best at all, because we see World Health Organization, OECD, they are working on different health-related aspects and frameworks. So instead of reinventing those wheels. I think collaborative and cooperative approach and how we can engage with those multilateral organizations that is going to define the G20 agenda as far as health is concerned. And what could these priorities be? So looking at the priorities, I think Indonesia has already set one of the priority, and that is defining a global health architecture. So in terms of defining that architecture, I think we should move forward towards defining the rules for genome data sharing, for having the global standards for the healthcare datas, because now we see different developed nations, even the US is suffering from the legacy issues of the HIPAA compliance. So that has become quite a old database, and they have tried to reform it over a period of time. But I think this is a very, very opportune time for the G20 to take this agenda and come up with the standards like we have in the electronics, IEEE come up with those standards. So it will help the patients, it will help the policymakers in making decisions, and moreover, it will help in the research and development, because there will be the interoperability of the data, and different institutes and organizations can really share those insights, and we can just prevent the world from reinventing those wheels or coming up with those insights again and again. Then similarly, many digital innovations we are seeing across Africa, across India. We see the Poshan tracker, for example, in India for malnutrition tracking. The Ashas are using technology. Then we have the health ATMs. Similarly, Africa has come up with a lot of health-related innovations which are very high impact and low cost. So we need to have a platform where we can share those ideas, we can customize those ideas, we can contextualize them to the local needs of the different nations. Then again, another issue where the developing nations, I think specifically India and Africa, can support and or can provide the knowledge is the community-based healthcare. During the COVID, we saw only people help people. No system can really help everyone. So it was the communities that were the center point. It were the people who were the local observers. They were the local influencers. We saw during the COVID, whether it was the phase of isolation or even the phase of vaccination, when no one was there to help, communities help themselves. And I think in these particular aspects, India and Africa are way ahead of the developing nations, and this is something that India can really give, how the social networks, how the local self-help governments, how different self-help group networks, the voluntary organizations, they came forward and they made sure that whatever the disaster that struck them, they provided the grassroots solutions, more customized solutions, and they provided the local insights for all kinds of problem solving. And coming to my next point, that is the technology agnosticism. We always talk about technology in healthcare, but when we talk about technology in terms of disaster resilience, we need to realize that at the level of the grassroots, technology is not always available. And even if it is available, the problem is the resilience is not as high. We may have multiple nodes providing us the internet connectivity in the urban areas, but if you see in the remote rural areas, there is a single node which takes the internet connectivity, and if it gets disrupted, then the entire system just gets broken. Therefore, any disaster resilience that we build, we need to make sure that it is technologically agnostic. And in case the digital tools that we have, they get broken, so we have something to work on. And lastly, there needs to be a coordinated response to any health-related emergency that we have. And for that, we need a global team of epidemiologists like we see in the aviation sector. In aviation sector, any disaster that strikes, there are defined protocols, there are the teams, there is an international group, but this is something we lack in the health. Everyone is on their own, everyone is doing their own research. So I think the global team of epidemiologists and a fund to support them, that can be a very good stepping stone for the G20 to move forward. And this is something where the priorities of both the developing and the developed nations will coincide.
Ravi, thank you. But before I let you go and before I go over to Priya, I have a very important question for you. What are those three things? And we just realized during COVID that it's not vaccines that matter, but it's vaccination that matters. And I think in India, the government has done a phenomenal job with COVID. You talked about technology, and technology remains and access, and then you talked about the challenges in access just now in terms of the non-inclusive nature of technology, especially in LDCs and developing nations. Um, how do you bridge the gap? Are people 5 miles away, 5 million miles away, rhetorically? How do you bridge that gap? So, what are those three top things in your view that India can do to build capacity here in Africa? And India, of course, is the pharmacy of the world, and I think India has a very, very important role to play. What are those three top things that India could do?
I think the most important thing, the first, and which India is already doing, is building a very robust digital health ecosystem that we call as the National Digital Health Ecosystem. So we are defining the standards for various health-related aspects, patient, provider-related aspects, and we have been very successful with this particular concept. If you see in the Aadhaar, that provides for the digital identity database, and also the UPI, which is the payment interface. So we are just replicating the success of the payment interface in the healthcare. So I think one of the tools that India can really provide to Africa is the digital architecture that we are building. We can collaborate with the African nations, and like we did with the CoWIN, that is the vaccination portal, which was open source and any country could have used in it. So I think first, the most important part is the digital tools that India is building that we can provide to the African nations. Then secondly, we can provide various patient safety leadership related lessons. We see it is not only about the structure and the systemic or the fundamental issues that are the major problems as far as health is concerned. We may work on the various implementation gap related issues. Implementation gaps may be due to the lack of knowledge sharing or the system design errors. So in those terms, India can be a very good resource for the African nations to provide for those patient safety leadership groups. And lastly, I would like to say that when we talk about health, so it is about the health technology in terms of the hardware. And that hardware India can provide at a globally competitive rates. We have a very large manufacturing base in India, and that kind of hardware, that kind of frugal technology, frugal innovations that India is coming up, many startups, unicorns are building on that. So that kind of knowledge sharing, I think, will go a long way in India and Africa relationships.
Yeah, thank you, Ravi. And now over to you, Priya. Yesterday, Priya, we heard some very interesting semantics. Selfish powers versus big powers versus selfless powers, and sometimes it's very easy to get mired in the complexities of semantics. Priya, my question to you, of course, is that what is this? How can this emerging Troika help to redefine and revisit, and considering that you have multi-nation experience in health governance, reimagine global health governance and ensure a more equitable architecture? What is it that we need to do?
Thanks, Jaibal. You know, I'm just going to start by saying that I think COVID is the best thing that happened to the world. It's the best thing because after the longest time, health is finally firmly up and center in terms of every discussion, whether it's the G20 or the COP27 or the hundreds and thousands of other acronyms that float around international development today. So thanks. Thank you, COVID. And thanks for giving us a wake-up call to realize a very fundamental truth, right? Health is wealth. And it's only when you lose it that you realize how valuable it is. And I think increasingly countries are going to have to manage that a healthy society equates to a healthy economy. Because I think if one thing the last 2.5 years have shown us is that when countries closed their borders and fell sick Their economies tanked. And it's going to take a while for us to get back in motion. But having said that, as human beings, we rarely learn from lessons that the metaverse deals us with. So here we are, in a pandemic that has affected every country. And there were institutions, largely multilateral and many bilateral, calling for global solidarity. And yet, every other nation responded with a sense of nationalism. They responded alone. They did not respond together. And I think there is something fundamentally flawed in the way that we think about ourselves as a planet and as a world. I mean, there are multiple conversations happening in this dialogue about sustainability and climate change. But at the end of the day, we have one life to live. And after that, we're fossil fuel, pretty much, right? So I think this has long and far-reaching implications in the G20 and who has its presidency and what they choose to do. In fact, one of the key areas that the G20 can work on is to reduce the asymmetry in vaccine equity. Never before. So there are two things that I've observed. One is this utter selfishness in terms of distributing the vaccines. But the other is this incredible scientific collaboration that was almost magical, that allowed these vaccines to be developed. Countries were sharing data. There was incredible amount of scientific rigor in the kind of work that went. But the minute the vaccines were developed, every country, at least the developed world, who had access to those, put their shutters down. We have to rethink the way we think about ourselves in the future. And the G20 members, interestingly, G20 members as a whole have received 15 times more COVID vaccine doses per capita than all the sub-Saharan countries put together. So that has to be an agenda, and it has to be number one. The second area where I think there is partnership is also to deal with the kind of priorities. That was one of your questions. So what are the new health priorities? So COVID has happened, it has devastated a lot of us, but do we have lessons? And there are a couple, and if you allow me. One is to rebuild our health systems, but not to rebuild them the way they were, but to rethink them. Health systems are going to have a fit-for-purpose health workforce. We have to train our doctors differently. We have to train our health workers differently. That's number one. Number two, coming back to Ravi's point, we have to invest in a whole-of-society approach in empowering communities. At the end of the day, states will fail. You cannot put the onus on them. The biggest problem with many countries is poor governance. So no matter how much aid you throw at them, if they are not able to manage that properly, if they are not able to manage their governance structure properly, it's a moot point. So we have to invest in the communities. At a point when everything shut down, it was the people at the end of the day. Health system architecture that deals with health surveillance. That is something that multiple countries need to do. And the Global South has been very weak at it. We've never put surveillance at the top of our agenda until thanks to COVID. And so here we have India brushing up its surveillance capacities. Suddenly you have technology. Suddenly you're learning to read data and tell a story from it. Never before have data scientists and epidemiologists had such respect in India other than COVID. So, I'm very thankful to that, and I hope it doesn't change. The third is new models of healthcare. We live in mixed health systems. You have the state, thank you state for coming back, because COVID forced the state to do something despite bad governance. But we also had non-state sectors that really stepped into those gaps. You had private companies, you had development organizations who banded together and made things happen. This is the future. It is not going to be state-run at all. And these are implications for Africa as well. What can India give Africa? India can give people. It can give ideas. It can give challenges. It can give many things, because these are countries that are in a similar state of flux. And that is a good thing, because if there is a time to rethink the way we access health, this is now. And if we lose this opportunity and go back as business as usual, the next pandemic is going to come along and we will repeat the same process all over again. We need to rethink about how health systems are approached, who are the partners, include other partners into the health system, and more importantly, use technology to facilitate all of this. So the third area, the two other areas, do not give up on NCDs. COVID has come, COVID will go, it'll come again. But 71% of global burden of disease is your NCDs. Get back to focusing on that. Do not leave infectious diseases. 90% of sub-Saharan Africa, the deaths are because of infectious diseases. They were the first on the uptake. So this continuous reaction of the African continent being constantly back-footed was actually a misnomer. They reacted, and they reacted so well despite not having the vaccines. So these are lessons that G20 can share amongst ourselves. This is not about one country teaching the other, but more a peer-to-peer learning process. And I sincerely hope that India and its G20 presidency initiates southern peer-to-peer learning networks. This is the time to do it, but not alienate the global north. We will always need them for a certain sense of direction, but we need to reach out more among ourselves. So that's the third point. And the last is AI and big data. This is the calling, whether we like it or not. Our lives are going to be ruled by artificial intelligence. Google, Facebook, they are going to dominate many, many ways in which we are going to look at health. And if we do not start thinking about digital architecture, digital standards that are applicable across many countries and openly shared with Africa, we are doomed. We will be a prisoner of a few companies, because that's what the future is going to be. So we have to embrace technology, we have to embrace entrepreneurs, and we have to create a governance structure that is both inclusive and extraordinarily transparent. Otherwise, it's going to be back to square one. And finally, a small point on institutions. It's really interesting. I study health systems, and what we have is a fractured ecosystem. We have large institutions. We have the UN, we have the WHO, and we have the banks, and we just talked about Bretton Woods. And one thing that I have seen is that international organizations which were up front and center of global health are no longer in that position. They have been shifted aside simply because the health system is so large. And when that happens, there have been several facets of, approaches to the COVID-19 landscape by countries. China, the US, which has always been at the forefront of global dialogues and global health, adopted an isolationist policy. They did not fund the WHO. They stepped back from the UN. China, on the other hand, was busy gathering allies everywhere, marketing Sinovac. Europe, stood fast by its multilateralism. And countries like India began to, for the first time, leverage health diplomacy to Nepal, to Sri Lanka, because of the ability to manufacture vaccines. So I think all this has kind of changed the global order. And what we have seen in terms of global governance is the shift from a universal system of one or two international organizations to multiple actors coming together, non-state actors, powerful philanthropies like the Gates Organization, and now more recently Mackenzie Bezos, and celebrities who are all, kind of bringing a public-private partnerships and so on. And they all kind of, even though they lack the legitimacy of an international organization, they come together as club models. And they are, picking up the gaps. But the problem is many of these newer health partnerships, they were not intended for a truly global initiative. So if you ask me, at the end of the day, there's going to be a phased decentralization of the global world order. And what you're going to see, the future health architecture, is going to be multipolar clubs rather than a universal approach to governance. But having said that, the UN and WHO do not lose their relevance. They will be convening bodies to those who want to join. And those who do join will have the ability to change the way we think about governance. So I'll stop there. I think I've said enough. Thank you.
Thank you, Priya. Priya, but as a post-colonial scholar, I of course have a question to ask you, and we talk about Orientalism and vaccine responses. And I actually wrote 2 pieces around the Orientalist approach, which we saw in 2021 and 2020. Do we see new Orientalism again? Is it selfishness or is it self-interest? What is the morality question? Aren't nations allowed to put their self-interest before they decide on global philanthropy? And isn't it the responsibility of individual nation states to build their own capacities? So are we laying the blame unfairly on the global north?
I don't think we are laying the blame unfairly. Self-interest is a natural cause. Everyone has a nationalistic self-interest. I don't think it's solely selfishness. I think it's insecurity. And I think the global north, which has always been the north pole or the compass of doing things a certain way, ruled by institutional rigor and institutional heft, for the first time felt insecure because they themselves were impacted by this. And so it's like, for the first time, I think COVID is a great leveler in terms of whom it has affected, because it has affected the rich and the poor in the same way. So a rich man's daughter and a poor man's daughter can both be affected and be gasping for oxygen. So in a case like that, I think the rich countries' automatic reflex action is to hoard. And that has to change, and they have to be brought to the table to discuss this. I mean, you cannot preach to others and say, be free, adopt a moral stance when it comes to, manufacturing of vaccines, manufacturing of taking of resources, for example. I think it has to be a dialogue around equity. So, I mean, the US, for example, had a surplus of vaccines at one point and did not distribute it. And it just lay there. So I think, this question of insecurity driving your global health agenda, it's not going to work. There has to be a point where countries have to decide what works best for everyone. Because we are in an interconnected world. We cannot detach ourselves. We just saw 2.5 years of shutting borders has produced vertical silos of everything. Everything has been affected. So if we are all connected, we cannot afford to allow our insecurities to overtake global mandates. And that is what global governance needs to bring to the table. India has to push that agenda strongly and muscularly in order to allow, for the first time, because developing and developed countries are on the same table, we have to have a more muscular approach. So I don't think it's selfishness, but it's definitely self-interest.
Thank you, Priya. Jose, I'm going to pose a couple of very tough questions to you. You're from the WHO. Yesterday, she spoke about how transnational flows of people are impacting our response and should be factored in when we deal with pandemics of the nature we are facing now. On the one hand, we've had Ebola and monkeypox endemic to 11 countries. Monkeypox has been endemic to 11 countries, and Ebola has been here since the 1970s. And just across the border, a few miles as the crow flies, we've had 50% fatality in the Democratic Republic of Congo for Ebola, and 750 years, and WHO declared it a global health emergency in 2019, and now monkeypox in 2022. Again, DRC had the highest fatality rate for monkeypox, though of course it's 3%. well, it's around over 50% for Ebola. Why is it that, and Priya talked about multilateralism and collaborative approaches. Why is it that we respond at a time when these permeate the borders of the global north? Why is it that we do not invest sufficiently in building capacities if they've been endemic for 5 decades? Why haven't we built capacities to ensure that these issues don't cascade to become global emergencies in the first place? And therefore, going to my question, how do you think the G20 nations, the three G20 nations' upcoming presidencies, can help influence and reimagine the global health governance architecture, and how do we shape our responses? What are the new things and new ways of doing and thinking that are called for at this time?
Thanks very much. I want to say, first of all, that I am at WHO, but have not worked particularly with the pandemic. I'm in a different part of health, so I want to be careful not to give a broad answer that's misleading. To your specific questions, transnational flows, these kinds of issues are features of complexity, really, that we have so far failed to understand or to embrace and address. So that's part of the broader approach that we need to be taking to understand complexity. There's also the mismatch between consequences and resources, so we need to find ways to align incentives. I want to talk about the G20 and the potential priorities. I want to agree with Priya. There's never been a time where health was a better lever for action, for change. Maybe in a negative way. As an epidemiologist, you'd rather be in the background and not so prominent, but here we are. But because we're talking about health priorities, and I'm going to take quite a different approach than my other panelists, I want to say something about what we mean by health. The dominant framing of health is around the health sector. If I say health action, people tend to think hospitals or health ministries or pharma or genomics, so on and so forth. There's also a tendency because of that to think, well, that's not my issue. Let's leave it to the health people. The health sector is critically important in health, but it's only part of what determines health. Health is an emergent product of our experiences in the environments where we live and work and play and move and pray and love. And for example, I work in urban health, and the way that cities are designed and organized and managed has profound impacts on our health, independent of the health sector. So we think of economics, in a very broad way. Every action we recognize has an economic cost or a potential benefit. We all think of ourselves or recognize that we are economic actors. The same is true for health. Every action that we take in development has a cost for health or a potential dividend for health. And so we need to start thinking of all development action as potential health action. And more than that, we need to start thinking about all of us as health workers. We are all health workers, whatever sector we're in. So I think that the G20 can foster a broader conception of health and certainly foster international action to place health more squarely at the center of the broader development discourse and unlock finance, for example, for climate action via NDCs, for urban action via national urban policies, for local action via VLRs. But let me talk about three broad priorities that I think the G20 should be focusing on. The first is to manage the urban transition for health and sustainability. A large majority of people in this world live in cities already, and that's an increasing number all the time. And they live in cities that are not designed to foster their health. And just to give one example, more than 9 in 10 people in this world breathe air that doesn't meet WHO air quality standards, including here in Rwanda. 7 to 10 million deaths a year from air pollution. Those are COVID-level numbers, but we don't see a COVID-level response. Cities are also the driving factor behind global environmental change. They are responsible for 3/4 of all emissions, 3/4 of resource use, 80% of global GDP. And we're just getting started on cities. By 2050, we'll add 2 billion people to the urban population. A majority of the urban infrastructure that we need in this world hasn't been built yet. So the impacts are going to become much larger if we don't act well. There's a tremendous opportunity to achieve health and sustainability through effective, sustainable urban development. For the past year, I've been working with the World Bank and the WHO. They're both embracing these issues, urban health, healthy cities. So this is an issue that's gaining currency, and I think the G20 could do a lot to make it more prominent. The second priority would be to build local resilience everywhere and foster self-sufficiency where feasible. COVID has really revealed the dangerous fragility of global systems and the dangerous over-reliance of one region on another. I mean, you need some connectivity in the world. There are benefits to connectivity, but you also have to have self-reliance, and that's increasingly true as we face a regime of more variability with climate change, with interconnecting issues. COVID is not the most disruptive challenge that we're going to face. Climate change will be significantly more difficult. And to be honest, right now, I'm not sure that I'm confident that if we had another pandemic, that we'd be in a better place to meet it than we were 3 years ago. Perhaps we're in a worse place. Climate change will be more complicated. So this implies a whole range of actions that we need to take to build local resilience. Things like building social capital, focusing on community capacities, fostering integrated information and practice across sectors and scales and geographies, investing in the technical and the human dimensions of adaptation. As our colleague from the Maldives pointed out, foregrounding debt relief and loss and damage, both as key obligations, but also as practical mechanisms for making progress on resilience. And a third priority, just briefly, is that I think that the G20 can raise or should raise the ambition on the provision of basic services. We live in a world where 2 billion people still lack access to clean water, 3.6 billion to safe sanitation, 2 to 3 billion to adequate housing. And these seem like really obvious things to say, but the truth is, especially in the city space, we're looking more and more at a focus on technological solutions, hypermodern solutions, smart cities, big data, data twinning. I don't want to get in trouble here with either my panelists or with anyone else here. I'm a strong believer in technology. There are clear equity and health dimensions to digitalization. There are clear opportunities for health through technical solutions. But we shouldn't lose track of the transformative potential of the simple things, right? We know we need to do those things. Basic health supporting infrastructure underpins resilience and sustainability. It frees people to engage in cultural and technological innovation. It supports better lives, which is really what we're all about, I think. So I'd like to see a renewed focus from the G20 on creating the political environment to support closing those gaps once and for all. Thanks.
Thank you, Jose. Jose, one other question to you is there a need to reimagine and revisit the post-World War II institutions which have remained at the forefront of the COVID response? And do you see the need to infuse new agility? And what is it that we need to do? And are they, we talk about new multilateralism, etc. How do we align these institutions to be more agile and more responsive?
So that's a good question. I think there's a need, but also it's something that we're seeing. I mean, we just heard it discussed in the most recent session. The multilateral system is changing. It's changing because of the ideas and the energy and the evolution of the world, but especially of the global South. I'm not sure that I'm in a position to say what those solutions should be. The solutions have to come from the global South. I think there's a lot more opportunity for South-South collaboration. I think there's certainly opportunity for more humility in the world and a new approach to the way we dialogue with each other.
Thank you, Jose. My last question to Grace here is, when we were manufacturing the COVID vaccines in India, we realized that we needed almost 360 sub-ingredients, which came from 12 countries. 200 of those sub-ingredients came from the United States, over 100 from Germany, and the remaining from countries like Poland, Denmark, etc. 12 countries. And what it brought to fore is the challenges in the global supply chain. Organizations there were not ready to ramp up the kind of production that we needed. In Africa particularly, why is it that after so many years, so many decades, and countries have been independent here on the continent for a while, why has capacity building not happened? And what is it that we need to do here to build resilient supply chains, to integrate ourselves to global value chains, so that we are in a position to respond with greater agility to pandemics such as COVID and even natural disasters, for example?
Thank you for, it's a very difficult question. In global health meetings or scientific congresses, we always start with, we know what the problems are. We know what the issues are. For the low-income countries, we know why they are exposed to infectious diseases all the time. We know why many children die of diarrhea. We know why many pregnant women are affected by malaria and there is no vaccine. We know all these things. But take it on from there. How much can we talk about in terms of health financing? In my country, we are not just boasting, but we have so many surgeons, we have so many pediatricians, we have so many people who have trained in the USA and other high-income countries like Germany in genomics, all types of sciences. And this knowledge can be translated into practice. I think this is the gap. And so when you talk about manufacturing vaccines are one of the most expensive ventures in global health. This one I have to agree. For instance, if you talk about Pfizer, Sanofi, Aventis, these are really resourced institutions. And if an African country, for instance, South Africa, wants to compete with Pfizer and wants to compete with Sanofi, Aventis, you don't have only financial barriers, you also have rights, patent rights to surmount. Yeah? So I am very glad that India sometimes does waves their TRIPS card and says to access these technologies is a human right, and we are going to make it accessible no matter what. This Uganda can do, but I think we have more hurdles to surmount. And I have faith. I normally want to look at the optimistic side as a teacher of mental health, that one day we can do these things. One day we can reach there, and one day we can make our own vaccines and even share with others. You know very well that Uganda has, for instance, even been recognized globally in terms of sharing the little they have. And if it is vaccine and it is manufactured in Uganda, I'm sure that they will share it with others, just like India is doing. But I must recognize that we have so many hurdles to surmount, and one of them is health financing. The other one, though, is about human rights. This is not a neutral field that we are talking about here. Global health is very much a political arena. This is what many people do not want to acknowledge. I am glad that you brought it up. It is not, I have an idea, I want to implement it and I'll work with it. It has many legal frameworks to govern it, yeah? And for instance, I think you know that AstraZeneca was as a product from India was only problematic in itself, yeah? And we don't want to go through all these discussions, but all in all, I want to thank India. I want to thank countries which are out there, sometimes about taking risks, you see, to make sure that the communities which we are talking about are not just theoretical communities, but real people, yeah? Real people who need assistance, for instance, real people who need vaccines, and to make these technologies accessible and even to manufacture them. Yeah, it's a complicated process.
Thank you, Grace. I would have loved to ask you one more question on the regulatory hurdles, which has also made the even within the East African community. But I have been told that I do not have much time. Probably I'll just take one question from the audience. Anybody has a question? Yes, please.
I've heard now numerous times that people believe that COVID was an equalizer. And I think the first thing to say is it was absolutely not an equalizer. It actually really showed this cavernous gap between the North and the South, more than ever before. So yes, the illness is the same no matter what, but COVID actually showed us how far apart we were from one another. So when we look at COVID and the whole issue of equity, I think somebody raised it here. In Africa, for example, we could not get reagents for even the COVID tests. Africa CDC could not secure reagents because the northern market held it and would not provide access. That's not an equalizer. So when you look at, when you talk to G20, those are some of the issues that have to be raised in terms of equity. On the issue of, you said it's not COVID testing, it's COVID manufacturing. So let me come to that very briefly. On the issue of vaccine manufacturing, we could have manufacturing in Uganda, we could have it in South Africa, we could have it in Senegal, anywhere. The issue is not necessarily just the manufacturing. The issue is that there is no supply chain and there is significant market shaping that needs to be done to ensure that Uganda's vaccines, South Africa's vaccines, Senegal's vaccines can be absorbed into the existing mechanism. Most countries in sub-Saharan Africa are reliant on Gavi. Vaccines go through COVAX facility. So unless COVAX absorbs these vaccines that we're producing, we don't have a market for it. Europe won't buy it, the US won't buy it, India won't buy it. So I think we need to think a little broader about, not just enabling, but creating the market space for manufacturing and supply chains to be delivered to the last mile and also to be profitable for those countries. So I wanted to just talk about that a little bit, and maybe that's something to take back to G20. On digital architecture, very, very critical, and I actually appreciated that you brought that up. I think the issue in most sub-Saharan countries is the issue of regulatory and policy, is not strong. So it's that capacity. How do we build the regulatory and policy frameworks for sub-Saharan Africa? What are mechanisms or examples of these in other countries that we can look at and learn from? And then, of course, create frameworks that are relevant to us. So I think that's really important. And then the intersectionality of health you brought, I think, across sectors. So the solution has to be more of the One Health approach. When you think about, for example, health and all of these issues like Ebola, etc., our people live with animals and people. There's a lot of connectivity. That One Health approach has to be strengthened, and we need to look at the environment as a whole that the communities live within when you think about interventions. So I appreciated that. And then finally, if you allow me, I just want to say, WHO actually in Africa, WHO Afro has been really significant in terms of building the capacity of health workers, epidemiologists, and such. So there is a very strong role that agencies like WHO play as well. So thank you very much for that.
So thank you very much indeed. That's all the time that we have got for this discussion. Thank you very much, Your Excellency Grace. Thank you very much, Priya and Jose. Thank you. Thank you very much. Ravi.